To know. So what we need now with the help of the face scanner is to orchestrate the facial, labial, gingival harmony, which is taking into consideration also the form of the face and is able to give us also a perfect gingival line which can be then transformed and to lead us to the final result. What is the third chapter? Make is the manufacturing of the guides through printing. Printing, Ronald, printing is not the future, milling is the milling. So in a way, that maybe we have other technologies there, but right now it is like that. So we print with a high accuracy, more and more, higher and higher accuracy, all these devices. And last but not least is the done. The done is the surgery which is in single tooth, in multiple implants, in full arch rehabilitations, with all the guides which are out there, with static and dynamic navigation is the last chapter. And in full arch rehabilitation, which we look retrospectively to all the full arch cases, which not all, but part of the full arch cases which were in this study they made with University of Frankfurt, we have a high success. What kind of success? Aesthetic and functional success, as I will show you at the end. And I don't know if I fit in 12 minutes, but nevertheless. So, we start always with an aesthetic planning, which goes and starts with the face, actually, and we go from the face to the crown height space to the OVD, and the OVD gives us the crown height space, and we split the treatment in FP1, FP2, FP3, whereas we strive always to give an FP1 and to change, well, we don't have time today, but there are methods to change from FP2 to FP1 by managing the soft tissue. Nevertheless, so one of the cases which we started to do, just to show you which is the workflow, what used to be the workflow and which step we did and why we did that, because we strive to accuracy. So this patient is an FP1 patient. We did at that time also a manually matched laughing scan and implemented also the movement, increase the OVD because the patient needed it. And here are the algorithms in this patient for aesthetic to establish the smile design, the implant design, and all these parameters which you see there. Now, the patient gets a lot of implants, and we plan it with two supported guides. We decide if it's cemented or screw retained, because we know that sometimes cannot do screw retained, and we have aesthetic parameters to place the implants. And this is also a take-home message. We talked today about aesthetic parameters, not only facial, but also gingival, dental, right? So we need to place 4 millimeters implant, 4 millimeters in the depths and 4 millimeters from the most buccal contour. So then we print the guide and the provisional at that time with holes. I don't really like them, and that is the provisional in advance. We go for the surgery. Those are the perfect positioning of the implant in order to get to the best aesthetic possible. And also we graft all these gaps in a certain manner. As you can see there, we have principle, we have parameters, we have biological parameters to work also in a guided workflow. And a biologized seal in order to create a height of the tissue. We need a height of the tissue when we talk about adjacent implants, like in this case. But this is all coming from the freehand surgery. Nevertheless, this is the provisional. So now it's the question, when we do cemented, what do we need to have? We have that individual abutments which have to be designed in a way that is creating papilla in between the implants. And the technologies is possible for the technologies through artificial intelligence to make a full digital workflow and to trace the margin of the abutment the way it should be. So use those technologies. And yes, the second wish list is to have a CAD system based on AI connected to the Ray face scan and to the smile design going to 3D. So that would be awesome because the technologies are possible based on AI. And also other dimensions, other aesthetic proportions, it's 3 to 4 millimeters from the margins of the abutments when you do cemented in order to give the space, the papilla to grow, as you can see in this cemented situation. But nevertheless, we have here what we want, screw-retained rehabilitation. So screw-retained rehabilitation, full arch scanning. Full arch scanning is a challenge, right, Ronald? Yesterday we were talking about that. In short spans is okay, but in full arch we need studies which shows the accuracy of the full arch scanning in full arch rehabilitation. We know that a scanner which has an intrinsic error less than 40 in mesh-to-mesh method, in less than 25 in nerves-to-nerves, is accurate enough for full arch rehabilitation. But this is not the only reason. That's why, the Optiv splint and so on doesn't really work, because we have an incongruency between the image and the library file. And this is another origin of an inaccuracy. We have differences between the scan bodies, which is also origin of inaccuracy. And many, many other factors. That is, and also the jumping distance. And that is why, in this case, we use the continuous scan strategy, splinting the scan bodies in the inner side. That was the beginning of other technologies which help us in the full arch scan. So we jump from this situation to a final situation, which is one-to-one, and the patient is happy. This is what we want. Now, a step forward. Still, we did photos, and also we started with the segmentation, and I love the segmentation, and I am envious that you have the ray fusion and I don't. Okay, so so I hope I get it. Yeah, so that is why